So we have about 15 minutes for you guys to ask questions from us on the panel about having heart failure and what happens to the heart, how you deal with your diagnosis, or how to embrace it from a psychological perspective.
I think we have our volunteers with mics, or you can submit the questions or your comments, share your story about how the focus of this next 15, 20 minutes is really talk about how did life change the moment you were hit with diagnosis. And a part of the discussions were, to identify that the coping, depression, anger, these are expected, these are natural. So if people can, whoever wants to raise your hand, they'll get you the mic. And if you want to submit any questions up in the poll, we can focus on also the medical questions of the heart and things that Dr. Trachtenberg does.
Are there antidepressants that interfere with heart function?
So there are antidepressants that do not interfere with the heart function or the heart meds. There are rare things we need to look out for if patients have EKG abnormalities that would suggest they have a higher risk of arrhythmias. But that's a very low percentage of our patients have that. So for the most part, antidepressants are very beneficial for our patients, and we recommend them even if they're taking lots of heart medications. But we do sometimes, depending on the medication, need to check an EKG first. Great question.
And in general, there's a lot of studies which have shown that by just having a heart disease or a heart attack or a bypass surgery, you're at a high risk of going into depression. And if you don't treat the depression, the cardiac outcomes also get worse. It's the mind and the body, everything is connected. So there's not just overall doing better, but if the depression goes untreated, the heart outcomes also get affected. So there's a big push for us to make sure we recognize it. And also the flavor, and I'll see if Dr. Chung has comments. In my mind, it's not as much if you have depression, you got to get on a pill and get stuck with it for life. It's the question of recognizing that you are predisposed to it, and it is the question of recognizing that beyond a point, it is a disease which becomes chemical. But it's not just taking a pill and walking away. And if maybe Dr. Chung can elaborate on treating depression is beyond just medications. There are counseling, there are things that you can do with it, minor lifestyle changes. So sometimes the taboo becomes, I don't want to see a psychiatrist and just get a pill. I'm fine. So Dr. Chung, maybe you can comment on not just medical treatment, but there's a whole line of changes that people need to do.
Sure, and what we've seen is if you have depression, you're 2.5 times more likely to end up with a heart condition. And it's interesting to realize as we're working to break the stigma, in all the diseases Methodists treat, we only have one psychiatric unit. So that says a lot, right? So we're really not embracing holistically looking at our patients early up front. Last year, in my program, we treated over 4,000 patients with depression, but we're catching them in our acute care unit and starting the journey of breaking the stigma by offering regimens. That's not necessarily just drugs. Just having healthy relationship with your family members is just the early start of your journey to be able to communicate. We have a society that's digitally versed. Everything is through technology. Just peeling that layer back and just learning to let your heart open up and having dialogue with your family member is an easy prescription. Helps with depression. Activity is key, and even cues that we're using is early screening for substance use and alcohol. Smoking cessation is huge because we know if you're smokers, the plaque formation impacts the heart. So all those early parts are things that we look for. And then if you happen to be a patient in our unit, we're not just necessarily pushing the meds. Our early journey on our unit, patients spend 90% of their time in group activities, because in psychiatry, we realize that group is important. And we're teaching coping skills, journaling, and different activities. We even just recently had a donor, again, going back to music therapy. It's the simple things in life. It's not just medication. And I think everyone is afraid of the stigma of dealing with mental illness because you think of the drugs and how you're going to be separated from society. We're here to change the stigma, and it's not just the medication.
So I think we have some questions that came into the poll. I think they came from, the first one was the bottom to top, if I'm not wrong. The first question is, Dr. Brewer, what caused your heart failure?
Well, that's still, I guess it's still not quite clear. I didn't have the traditional risk factors, high blood pressure, diabetes. I was very physically active. It's not quite clear. I think Dr. Bhimaraj and I, we've tried to figure out this puzzle, and I think we're kind of at the mindset that it's probably more genetic related, but the understanding of how I developed this is not quite clear cut.
So I might just add a comment on that. One thing I didn't mention in speaking about the different types of heart failure. So if we say that about half in this country are due to heart attacks, the other half are not. And of the ones that are not, as high as 30 to 50% of those are due to unknown causes. We call it idiopathic heart failure, meaning we don't know the cause. So we know that a decent proportion of those idiopathic heart failure, the ones we don't know, can be genetic if you do a careful family history and gene testing. But even among that, there's a limit to how much we know about genes that cause heart failure. So there's still a lot of unknowns in this field, and we do have a lot of patients that do have heart failure, and we don't know why. They don't have any of the traditional risk factors. Often they're young, so there's a lot more we need to learn. But there's the main theories are genetic or possibly viral myocarditis that is not properly diagnosed or able to be properly diagnosed. But there's a lot of different other causes that could be there as well.
Yeah, and I think the important, as we had mentioned, 50% in our country have a reason for heart attacks and blocked arteries, which is very keen to make sure you don't have, because if you have blocked arteries, we can fix them. You have a heart attack, if you have more blockages, that's a fixable thing that we can at least intervene while you take medications. The other 50% have a mixed bag of reasons, of which a big, when we say genetic, some of them run in families, but majority of them, it's not like a genetic predisposition in the family, it's just because that individual is born with a change in one of the genes which makes the heart go into weakness and heart failure. And sometimes we say it's a double hit hypothesis, which means that they have a susceptibility for injury and a virus attacks your body, and then the body confuses the heart to be like the virus and attacks it. I mean, in one essence, these are all theories that we're still struggling to understand, and no matter what the cause is where we come down to. Our belief is if there is a cause, there are certain things which are rarer causes. There are things like sarcoidosis, amyloidosis, which are different, they're rare diseases. As doctors, what we do is make sure we eliminate things that are not changeable by other treatments. And if there's no other reason, then you're stuck with this diagnosis of what we call as dilated cardiomyopathy, or dilated just means the heart is bigger. Cardiomyopathy is a heart muscle weakness. It's as simple as it. We're just making up terms because we don't know what the cause is. So there's a lot of active research in that, and identifying the future 50 years from now, if we have to imagine, is a hope that it'll be personalized medicine where we can check a blood test or a biopsy of the heart and look at the genes and then identify why they have the problem. But for now, as Wayne mentioned, he has a diagnosis which we don't know why the heart's weak, and we treat with the same medications. The other question is, with the past and current research at various facilities, why is there not a way to go back in stages of heart failure? In the stages of heart failure, as I mentioned, is the definition of that stage C heart failure just means that you have had symptoms at some point. So you can't go back once you have symptoms at some point. It's not like you are always feeling bad. So we classify it that way as stage C, means that at some point you felt bad and seeked attention. So you'll never go back to the past and change your past. So the definition just means that at some point you felt bad. Now, to the question, there, and again, actually we are doing a research in recovery. How do you recover the heart? Right now we use medications, and in one aspect you can actually move from stage C to stage B in one essence, but again, the definitions basically says that once you have symptoms, even if your heart gets better, you're still called as stage C. So the important thing to remember is sometimes people have a weak heart, right? That's the reduced ejection fraction that Dr. Trachtenberg talked about. On medications, you could recover, but that doesn't mean that you're completely healed. At this stage, we believe you need to continue to take medications to maintain that remission. So the stages are defined in such a way that you could go back from D to C at some point, but they're more of a scientific definitions to help us catch patients early on. I think we're running out of few. There's a question, yes.
So a person with this condition can have a normal pregnancy?
With heart failure, is the question, can you have a normal pregnancy? So it's, there's not one answer that fits all. It depends on what the extent of the heart failure is, and there's one of the key issues is there's the two main issues I would say. One is the medications that we use to make the heart stable and better. One of the main medications we use for that cannot be used in pregnancy, and therefore would have to be taken off, which has some risk, obviously. And then it also depends on the cause of your heart failure. There's different causes of heart failure that are more likely to occur with pregnancy, or it can be worsened. And the research from a particular type of women that have heart failure that's caused by a previous pregnancy, we know that the risk of having worsening heart failure or even death after a subsequent pregnancy really depends on how their heart responded to the medications and whether it recovered to near normal or failed to do so. So it's a complicated question. There's not I wouldn't say absolutely not, but nor would I say absolutely yes. It depends on the particulars of your disease, and so that's something that I have to be carefully discussed with a cardiologist and that knows your history well.
So I think we have a few more minutes. We'll have short replies. I guess the next question is, has the reality of heart failure overwhelmed your emotions on the job? Nurse Chung is asking, is it for the physicians or practitioners? Is that what the sense? I guess it's overwhelming for everybody. It's always overwhelming for the nurses and clinicians, if that's what it means.
I think, is that question for Dr. Chung? Has the reality of heart failure ever overwhelmed your emotions on the job?
I think it's probably the other way around, right?
Yeah.
We have a lot of, I can speak for just the stressors. We have a lot of Rice students that come to our unit, a lot of individuals of late who are showing up in our work environment, in our unit to be treated for stress in school. You go to an Ivy League school, it's huge, very stressful. And the stressors that people are facing on their job. I've had this person recently said his job requires for him to be there at times 3 days a week for 24 hours. That's stressful. So then as you look at the stress markers that lead to heart failure, you do want to bring those factors under control. If not, you're going to see the negative sequela of the impact on your heart. Sleep disturbance is huge in depression. So we really ensure that our clients are getting a lot of sleep, because other stressors, their cortisol level gets elevated. All these things have a negative impact on the heart. So I think, you need to pay attention to personal stressors, work stressors.
I think there's I think another really important question here that Dr. Chung can tackle. How do you encourage a family member to seek help with depression post-surgery? And I think you can apply that to any patient with heart failure. How do you encourage their family members to help them get help? And I know it's a touchy subject to bring in when you're family and and you know, to suggest they see someone for mental health disorders is stressful situation.
So we're rolling out the PHQ-9, and even pre-surgery now is where we're screening. And last week we had a patient who was coming in for a pretty big surgery, and because we're doing the PHQ-9, in that question, the patient depression score was very high, and the surgeon stopped even moving forward, and we sent that person to the emergency room for screening and got treatment for the depression before he would even pick up to move forward with the surgery. So that's our first unique case where we're pre-screening for surgery and making a decision that if you're not mentally well, that surgery sequela post-op, because it was going to be a big surgery, would have been negative. So the surgeon said, we're going to stop the line, and we sent the person to the emergency room to start treatment.
Yeah, and I think I'll add to that you know, I have patients, family members that pull me aside and say, Doc, you know, my husband or my wife, I'm pretty sure he or she's depressed. I can't get him to see a therapist. I can't bring it up. You know, they won't hear of it at all. And so they let their health providers know, and that gives their health providers a chance to bring it up when they see them in clinic. So that's one thing that can be helpful. But but screening them certainly pre-surgery is a great tool that hopefully will help family members get support.
And part B to that, psychiatry is the only discipline that we depend on the court when the individual is stuck in pre-contemplation and cannot own their disease state, that you as a family member can go to the court off 288 and get a subpoena to have the police pick that person up and bring them to our unit. So it's another recourse that you have where the court system fortunately will give the family support to do an involuntary commitment. And on any given day, I have a 20-bed unit. I would say about 6 of my patients are there involuntary because families recognize it, and sometimes you have to reach out to the court system to gain support.
Thank you all. I think the other questions we'll have them come back to as the session goes on.